Hi, everybody. There's a few more people who will sort of just trickle in here, but we'll let them do that. And there is actually hot water and coffee back there right now if anybody wants to get up at any point and go get them. So I'm Beth Donaldson. I'm that person right there, and I know about half the faces in the room. Good to see you all. Thank you for coming again, and thank you for coming for the first time and what have you. Some people here are members at Copeman already, and some people are just starting to get to know us. So if there's any questions along the way, just raise your hand. I've given this talk a couple times before, and it gets quite interactive, and we can go down sort of any road that you want at any point along the way. So definitely let me know if you have any questions, okay? So for those of you who are at Copeman right now, you should hopefully be able to actually give this talk, because we are talking about this stuff all the time. Every time that you are in to see a physician or a dietitian or a nurse, we're chatting about this nonstop. So hopefully this will just be review for you guys without too much new stuff, but we'll try and throw some new stuff in there as well, okay? All right, so let's get going. We're going to talk about prevention through the ages, and I've got a pretty good mix of age groups in here, so we'll go through a few of them, okay? All right, so we're going to talk about your general health risks, with those things that we come upon and can actually do something about during our life. One would be the big C, the cancer one. Next one would be cardiovascular, and then there's some diabetes in there as well. So we'll talk about all those things. Typical risk factors for those, which I think most people will be aware of what those risk factors are. Some might be surprises though. And then steps that you can all do to reduce your risks. And then we'll talk about an individual case at the end that kind of speaks to resilience and why it's important to build resilience throughout your life. Okay. All right, so the first one, cancer. Everybody's worried about cancer. It's actually not the one that kills most of us, but everybody's worried about it. So we tend to start off our talks with that disease. So unfortunately, 1 out of 2 of us in this room will get cancer. Everybody knows somebody in their family or loved ones, friends who have had it. It's really becoming 50-50 for men and women. There's not much difference there. And that's an old stat, 2007, now 10 years ago, but it's pretty much the same these days. Hope you can see that one there. We're basically dealing with men, 100,000 new cases in Canada per year. Typically, we get prostate, colon, lung, bladder. For women, we're looking at breast, lung, colon, uterus, or endometrial cancer. That would be the same. The interesting one that's up here that I like to sort of throw, there's actually 2. It would be the thyroid. We start to see thyroid in women. 5% of women will get that one. And then somewhere along here is the oral cancers as well. I don't see larynx. Those ones are oral. Those are coming up a little bit more and more these days. We're getting better at detecting oral cancers. You probably all know somebody who's recently had one. And often it's not even from somebody who's smoked. They kind of can come out in anyone. And that's where seeing your dentist now is becoming more important. It's not just for teeth health, but for oral cancer presentation as well. So that's sort of an interesting one that comes up there. Moving on. So this just gives us the different age groups and the most likely cancer that we're going to see, male and female together. So in this room, I'm betting everybody's about 30. So we're looking at breast, 25%, thyroid, colorectal, lung, and then as we get into the 50 to 60, more prostate, breast, lung, colorectal. And then as we get older, there's a bit more lung going on there. The thing that I love about this slide is we can screen for 90% of these. And it really kills me when I hear somebody who is dying of colon cancer because they didn't get screened starting at age 40. The younger than age 40, those are tough ones. Those are tough ones to catch, and that's always unfortunate when you get one of those. But over 40, we should not be dying from breast cancer. We should not be dying from cervical cancer. We should not be dying from colon cancer. These are things that we can screen for and that we screen for at Copeman regularly. Does anybody have any questions about when to start getting screened for colon, breast, prostate? Is everybody quite aware and getting screened currently? Yeah?
Just out of curiosity, what's the current thinking on screening for breast cancer in terms of the whole debate around
Yeah, so mammogram still remains the best way to catch breast cancer because it gets those little calcifications before they turn into a big mass. If you're feeling a big mass, then yes, you go on to ultrasound, but mostly to get breast cancer early, you've got to get your mammogram because you're not going to feel it. Often by the time you can feel it, it's too late. So you do want to start getting mammograms at 40. Start getting them earlier if you have a first-degree family relative who has had breast cancer before age 40. But mammograms still are the mainstay. Not MRI yet. We might be going that way. MRI right now is just for cancers that have already been found, and then we're trying to see if they are returning or to see exactly where they are in the breast. Yeah. Anyone else? Good. All right. So, it's again speaking of sort of what we are dealing with as we go through life. Talked about cancer. Now we're just going to look into cardiovascular disease. What does that actually mean? It's really just disorder of your vascular system is the basic way, and it is the leading cause of death for Canadians and those around the world. So that's even more so than cancer. So we're talking heart attacks, strokes, peripheral vascular disease, all those things that we do our best to prevent. And we'll get into how we prevent those coming up. So a few of these stats, I'll let you guys kind of read them here and highlight a couple. The interesting thing about heart disease and stroke is a lot of people are always worried about the stroke, the one that will kind of leave you partially here but not completely here and having to suffer sort of for your last few years or days of life. You know, heart attacks can do that too, and we often forget that. Heart attacks can lead to kind of a miserable existence, so it's important to prevent both. And I often tell my patients, I know that you're all going to die. My goal is to keep you healthy, healthy, healthy dead, as opposed to not healthy, sort of dying dead. So we want your quality of life at any age to be as high as it can be, okay? And then just swiftly leave the earth when it's your time. So those are some stats there. Cardiovascular disease in women was kind of a buzzword, I'd say, 5-10 years ago, and it's still out there for sure. Women haven't been part of the studies up until recently, so we weren't often talked about when it came to heart disease, but we know that heart disease in women is very serious. And what I find interesting, a few things, and we'll talk a little bit more about this, 53% of women are overweight. We'll have a few slides on that. 16% of women are more likely to die after a heart attack. One of the reasons for that is women tend to get small vessel ischemia or small vessel disease that isn't as symptomatic as sort of that big jammer that the men get, right? So women can kind of go through life and just kind of ignore symptoms for a year or two before they have their heart attack. So women, it's quite a gray area. It's important to discuss anything, even as simple as fatigue, or I'm more short of breath walking from the laundry room to the kitchen than I used to be. Things like that can be signs of heart disease for women. And then nearly 50% of Canadian women aged 65 and over have high blood pressure. High blood pressure is a silent killer. It's a bad one. We at Copeman really try and knock blood pressures down because it really changes your outlook and your chance of heart disease and stroke. And we'll look at numbers a little bit later for those, for blood pressure targets. Okay, so we talked about cancer, we talked about cardiovascular, we're going into diabetes. Unfortunately, we're actually not doing as well in Canada as we would hope. We all think we're like skinny and active, but we're actually not. So we're behind USA and Portugal for diabetes around the world. And look at this, the UK, I think they're down here because they're all skinny and they smoke, right? I'd love to see the lung cancer stats with UK like up here probably. So we're actually not doing great from a diabetes point of view. Diabetes means high blood sugar, okay? And I'll let you read some stats here. But the one that I want to highlight here is really this one. 90 to 95% of Canadians with diabetes have type 2 diabetes. Type 2 diabetes is the one that comes on later in life because we're fat and we don't exercise. Type 2 diabetes doesn't need to happen. We can actually prevent it. And with 7% of the population out there with type 2 diabetes, if they actually started lifestyle changes early and or got on the bandwagon, you know, when they actually got diagnosed, we would prevent a whole lot of medications from being used and save a whole lot of money. And healthcare dollars and save a lot of lives if people were just able to change that. And to actually have a preventable disease, you can do something about that. There's a lot of diseases out there you can't do anything about. So just keep that in mind when we're deciding whether or not we are going for our run today. Okay? Okay, so let's look at risk factors. I've kind of highlighted a few, but we'll look at them a little bit more. So risk factors for disease in general, we look at non-modifiable and modifiable. Age, obviously non-modifiable. Gender, you can change somebody's gender, but you can't change the genetics of their gender these days. So you've always got those genes, like you do with your family history and genetics. Modifiable ones, smokers. It's funny, I saw somebody smoking out there as I came in, and I thought, God, they're sort of like dinosaurs these days. You don't see smokers very often, which is great. Hopefully they're on their way out. You can be more physically active. You can improve your alcohol consumption. Most of us can improve our stress levels, and then you can obviously improve your diet as well. Any questions on those ones? Yes?
What do you think about smoking marijuana? That's going to be on the increase.
Yeah.
And we're all going to be passive.
It's true. It is a carcinogen, just like nicotine. It definitely is. It is a problem. Usually we're not going through as many joints as we are cigarettes, so at least the numbers are slightly down, but it is a problem. And secondhand smoke with marijuana is still a problem like it would be with cigarettes.
What about edibles?
No issue with cancer that I know of with edibles, so that's a potential. Mm-hmm. Other than potentially mouth cancer. Mouth cancer, I'd have to look into that. Yeah. So again, cancer risk factors. Speaking of cancer risk factors, these are all quite obvious. Alcohol, it's an interesting one. We'll get to what good alcohol intake is. But alcohol is good from a cardiovascular point of view at certain levels, but then it can increase your risk of most cancers out there if you're above certain levels. And then, of course, we all know about skin exposure and watching for changes in your moles, wearing your sunscreen, staying out of the sun, and then, of course, your environmental exposure. Secondhand smoke is a tough one because a lot of folks in this room would have grown up with smoking parents, and they kind of screwed you over. That just wasn't great, unfortunately. You have a risk as almost as much as a smoker would for the amount of time that you were exposed to that secondhand smoke. I like this slide, just sort of honing in on breast cancer for a moment. And a lot of people are always worried about what potential hormone therapy is doing from a breast cancer point of view. It's actually not doing much, and some of you in this room have probably seen this slide already, but if we look at this blue one, this is your increased risk of breast cancer if you have 2 or more drinks a day on average. This is your increased risk of breast cancer if you don't exercise. And this is the same if you gain weight after menopause. And that puts you, I forget, I don't have the stats on what this actually means, I apologize. But these down here are your extra risk from actual hormone therapy. So hormone therapy doesn't cause breast cancer, lifestyle causes breast cancer, and genetics cause breast cancer. Cardiovascular disease risk factors, again, we know this, modifiable and non-modifiable. A couple things I added at the end. Gout would be a modifiable risk factor if you can control your gout and your uric acid levels with medication or protein restriction, increase hydration, decrease alcohol. Gout in and itself is an inflammatory disorder that can actually increase the amount of plaque in your arteries. And then autoimmune disease. So those folks with Crohn's, with celiac, with lupus, rheumatoid arthritis, they actually have an increased risk of heart disease because, again, that's a pro-inflammatory state, as much so as, say, a diabetic. So we're starting to look at those people with autoimmune disease as seriously as we would a diabetic when it comes to screening for heart disease. Yes?
Just if your disease is uncontrolled, or is it just no matter what?
Mostly if it's uncontrolled, but you'd definitely be on a radar more just because you have it. Because you're constantly fighting that pro-inflammatory state, even if you're modifying your diet or on a medication to prevent it. All right, so cardiovascular disease risk factors and burden of disease. There's that high blood pressure. If something's going to kill you in life, it's going to be that high blood pressure. We need to keep it down. So when I have women who come in who are like, 115 pounds and they're 65 years old and their blood pressure is 90 on 60 and they say they feel dizzy, and I say, great, that's fabulous. I want you to be slightly dizzy. You're doing better than the people who are up at 140 on 90. Okay, just get up slowly and drink more water. Again, tobacco, smoking, we know that, alcohol use. This was interesting, diet low in fruit. Okay, we need to eat more fruit. Diet low in vegetables. Physical inactivity. We actually, there's actually research to support what we continue to tell you guys. Metabolic syndrome, have you guys heard of that one before? Metabolic syndrome, you need 3 out of 5 of these. You need to know what your numbers are for cholesterol and your sugars in order to do it. We'll get into the waste later, but that one triples your risk for heart disease and is 5 times the risk for, triples your risk for heart disease and increases your risk for diabetes by 5. So we want to have all these levels under control. Okay, this is great. So this is 2000, and we're looking at year 2000, only 20% of people in BC were obese. Northwest Territories not doing so well. That was the year 2000. Going forward, 2011, we got fatter. 20 to 25% of us were obese, unfortunately. We were sort of in there with the Yukon and Quebec. The next one is not quite a direct comparison slide, but it basically tells you in 2014 who was doing better. And again, BC and Quebec in general were doing a little bit better. Yes?
What's the definition of obesity?
BMI over 30 is over, I'm just trying to think, is obese. Overweight, obese. Yeah. So BMI is meters per kilogram squared. Everybody should know what their BMI is, but it really actually does come down to waist circumference, and I'll get into why that is in the next few slides. So people are getting a little bit too chubby around Canada as they are elsewhere. So this is the belly fat slide. I like this one. So we forget when we go and we measure your waist circumference in the office, we're not just looking at the fat that we can get on our arms. That's the concern. When I pinch this guy's waist, it's hard for me to feel my fingers on opposite side. What bothers me is that it's not this fat right here, it's the fat that is actually all around his bowels, his liver, his spleen, his kidneys. This is the stuff that acts metabolically different, allows you not to use your glucose appropriately, so that you are more likely to become diabetic. You become pro-inflammatory, which means you're going to be more likely to lay down plaque in your arteries in your brain, your kidneys, your liver, your heart, and more likely to throw up a clot and have a problem. So when we talk about waist circumference, it's this fat within your tummy we want down, okay? All right, what do we do to reduce action? Okay, be aware, look after yourself. So know your body, come to your physician or your nurse or whoever with any changes that last. So a change that comes on over 24 hours, watch it for a bit. It's probably not cancer. But if it's there for 3 to 6 weeks to 3 to 6 months and you're not sure, then come in and bring it to us for sure. Get screened early. Get to know your doctor in your 20s, don't wait till your 60s, because we can find things early and start to change your course of health if we get you in earlier. Know your family's history. Understand how hormones and infections affect you. The infection one really comes back to HPV. That's that virus that we now have a vaccination against, and we're vaccinating women, girls, and boys for it now, because it's not just a cervical cancer virus. It causes the anal cancers you're hearing about, the mouth cancers you're hearing about. It's causing quite a few problems, but we can prevent it. Like, how cool is that you can prevent cancer with a vaccine, right? It's the only one we know of. And then get rid of those harmful substances, some of which we really don't know about. Yeah?
That vaccine, I know that it's given to young people. Now, what about older people?
Yeah, So it's only been studied in young people, which is why it's only been given to young people. But off-label, we're giving it to women up to age 40. Yeah, without problem. But it started in young people because that's that's the only folks that it's been actually studied in.
Why don't they study that as opposed to broad populations?
Vaccines are typically given at younger age to affect the whole population as you age. But we do have great screening for HPV from a cervical cancer point of view. We can do anal pap smears as well, and then the dentist is continuing to look in your mouth. And the good thing about cervical cancer is if you're screened and you have a few regular normal pap smears in a row, we're actually extending that screening now to 3 years as opposed to 1 or 2 years like we used to, because we know cervical cancer is actually quite slow growing, and you're going to catch it every 3 years in someone who's never been exposed to HPV before.
If you've had the HPV vaccine, is regular pap smear still warranted?
Yes, you still need the pap smears even though you've had HPV vaccine. Yeah. And if you've had HPV and you've had a cervical cancer, you still get the vaccine because there's other strains that can come up and cause a problem. Okay. So improving resilience, cancer in and of itself, we know all of these again. Tanning beds, I think, are a thing of the past. I don't even know if they're still around. We'll look at some numbers coming up here. So, again, for your risk factor, know your numbers. If you are anybody in here, if you could get your blood pressure below 120 on 80, you're golden. You shouldn't be dying from a stroke or heart disease. A lot of people sit in around that 120 to 140 moderate zone, depending on your family history and your other risk factors like cholesterol and such. We'll probably try and bang that down below 120. Anybody over 140, you really need to be treating, definitely. Cholesterol, this is your LDL cholesterol here. We really would love it below 2, again, for optimization, either through diet and exercise alone, which is difficult to do, or medication. And fasting sugar is less than 5.6, and then your waist circumference, we're really aiming for ideal there, 37 inches for men, 32 for women. And I'll look at that.
Another question.
Yeah.
So on the blood pressure at 120/80, let's say, myself, for example, I'm like about 120/80 in the middle of the afternoon. That's a good number. In the morning, it's like 110/70 or something. But 15 years ago, I was like 95/65.
Yeah.
So can you speak to that? Is that, it's moving up.
Everybody's blood pressure goes up as we get older,
Okay.
in general. Yours at 120/80 is awesome. Just great, just thinking about how potentially old you likely are. 120/80 is great, and I'm not surprised. You're never going to have a problem with your blood pressure if you keep it, if that's what your blood pressures have been over the last 20 years.
But it's like way low.
Yeah.
Like, I mean, the guy pick a golf ball out
And get
of the cup
dizzy.
and pass out.
Yeah.
Almost, like.
That's a good thing. So no matter what, as we get older, our vessels start to harden. You can't prevent
Just
that.
the way it is,
It's just
right?
the way it is, yeah. And then it's funny because then, we fight our blood pressure, and then we could become 88, 90 or so, and we're not eating very much, we're kind of not moving, and our blood pressure starts to go back down as we sort of get closer to the end of life. Yeah, that's pretty normal.
And just speaking to that, in terms of the blood pressure getting up higher as we get older, as a result of our blood vessels changing, I understand now from some cardiologists that there is less emphasis on trying to get down to 80/120 in somebody who's 60, 70, 80 years old.
Yeah, it definitely depends on your risk factors. If you're diabetic, we still want to really hammer it down because it's definitely a risk with high sugars as well. But if you're older and symptomatic from getting your blood pressure below 130/80, it's not worth it. I don't need you falling and breaking a hip, for example, because of the blood pressure that you're on. But yeah, that tight control is really there for the diabetics and for those at high risk. And if you can tolerate the meds. So if you do fine on the meds and we get your blood pressure down to 120/80 and you feel good, great. Yeah. So some of you came in and had tape measures on your seats. I see them there. You put them to the side. If you're touching one right now, I want you to stand up, and I'm going to show you exactly where you need to measure your waist. You don't need to disrobe or anything, but maybe jackets, yeah. So when you're working with your personal trainers, you're working with your doctors, you're working with your kinesiologists, especially men. Men are the ones who I go and measure their waist, and I'm like, what do you mean I'm 40 inches? I buy 32 pants, but the pants are down here and the gut's up here. So it's got to be where they're measuring it on the screen there. So 1 inch above your hip bone, and then all the way around. Okay, and what you're supposed to do is take a deep breath in. That way, right? Get yours, yeah? Deep breath in, and then breathe it out. And then find out where you are. Okay? It is the hardest area of the body to get weight off once you get it on. You're doing great. Okay? You're doing great too. You might have the centimeters there, yeah. So, and, pass it around and have a look. You need to know your numbers for sure. Good. Everybody finding their waist okay? Yeah, just above your hips there.
Can you reference it to the belly button?
No, because belly buttons can change, right? Like if I use this gentleman right here, who happens to be my father, his belly button, where's the belly button?
Right there.
Is a bit lower than where I want to measure it. Okay, there's some people who have a lot of abdominal fat and the belly button ends up hanging down here, but I need it up 1 inch above the hips. That's where we're getting that fat, abdominal fat wrapped around the bowels. So, yeah, you need to lose a bit of weight. So this number, that guy, when he puts his pants on, he's measuring here. He's not measuring it. This is where I want to measure. So this number is more important than your BMI, okay, when it comes to your overall health. It's really, really very important.
What's the magic number?
80 centimeters for women, 94 centimeters for men. So inches, 32 for women, 37 for men. This is the measure that I try and counsel people before they get to age 40 that they need to keep in check. Because some people in this room will have realized that if you get past 40 and you have a high waist circumference, it is next to impossible to get it down. That being said, especially for the women in the room, once you hit menopause, you're guaranteed a couple inches on your waist. You can't do anything about it. Even Gwyneth Paltrow is going to put on 5 pounds on her waist, and she's not going to get it down unless she has a tummy tuck. Like, it just happens.
So if we have a tummy tuck, does that make yourself?
It doesn't. No, unfortunately it doesn't. Because you can get rid of the pinchy fat, but you're not getting rid of the fat around your bowels with the tummy tuck, right? They don't remove that. And that's actually a difficult waist to measure when people come in and they've had it done and I'm measuring their waist. I'm like, I'm going to add a couple inches because this isn't real. But yeah, as we get older, it's that one area that is the worst to get off. And so I always say, don't let it on there in the first place. So if you're chatting with your, friends or daughters or what have you, that's what you tell them.
Is there any diagnostic imaging that can see the belly fat?
Yeah, I mean, if we did an MRI.
Organs?
Yeah.
MRI?
Yeah. But we don't need to do that because we know that this correlates with the organ fat. Mm-hmm. Yes?
The difficulty I have with that measurement is it doesn't seem to account for the difference between a woman who's, say, 5'1" and very tiny and a woman who's 5'11" and much bigger.
It does.
It does?
It does.
It's the same waist measurement.
Yeah. No, it does. It definitely does. So no matter how extended you are through the waist, you can still have more abdominal fat than you need to. What ends up happening is you can have short-waisted people and long-waisted people. It doesn't matter what your height is. But because we're always measuring above the hip bone, we've got some consistency there. Yeah. Thank you for doing that with us. Okay, so again, improving our resilience. Again, you've got to be the shape you want to be going into your 40s and 50s if you're going to be able to maintain that later in life. It's really difficult to get a 65-year-old to start exercising when they've never done it before. It's almost next to impossible, I would say. But you can definitely change your eating habits, and 80% of weight loss, 80% of weight is what goes in your mouth, 20% is exercise. Okay? Exercise is important, but it's really what goes in that's important. So you need to do all these things, exercise as much as you can. And again, it goes back to improving your insulin and glucose control, but also we can get 40% of patients with type 2 diabetes off their medications through lifestyle and intervention alone. And that's pretty cool. So let's look at how much alcohol we're allowed to drink. I think that might be the next one. Yeah. So 15 for men, 10 for women. I usually say 7 to 10 for women and about 14 for men. Men get more just because of their metabolism. It works a little bit different. And I'll say to people, you could have all 10 on one day, but binge drinking typically isn't great for your health, but that would still average out. There's still some benefits to moderate alcohol consumption, don't get me wrong, but any alcohol unfortunately increases cancer. So I always say if you're sitting at home on a Tuesday with your cat watching TV, do you need to have a drink? Probably not. Wait till Friday when you're having a dinner party, right? Plan out your week for when you want to have that wine and when you don't want to have that wine. Try and have a few drink-free days during the week, alcohol-free days.
So how do they do that in Europe?
In Europe,
They consume a lot of.
they do, yeah. So you'd see certain cancers in the rise in places that drink more alcohol, mouth cancer, for example. Yeah.
In alcohol, like, does it matter what you drink? Like, there's wine or scotch, just to take an example.
Yeah, yeah. It really doesn't. It's just any sort of alcohol either is bad for you if it's too much or slightly okay from a cardiovascular point of view if you keep it to
So
moderate.
if you had a nip of scotch instead of drinking wine,
Fine.
same deal.
Yeah. Yeah.
They'd be able to prove that, or it'd be hard to prove.
Well, no, but if you want to design a study, I'm sure there's people in this room who would be happily involved with you. Yeah, and don't get me wrong. There's a little bit of good to alcohol too. Like, I've got this old guy in an old folks home right now. He's super sweet, and he's eating soft foods only. He doesn't swallow very well, and everybody's always told him he's not allowed to have his scotch at night. And I looked at him and his wife. I'm like, give him as much scotch as he wants. Honestly, he can have a couple to get to bed at night just to help him sleep. There's some good that it can do depending on your age and your risk factors. But in general, keep it moderate.
You say something about alcohol and medications.
Alcohol and medications. Alcohol and medications generally mix okay. I have a lot of people who are like, oh my God, I just started this medication. Yeah. Yeah, it is. Generally, medications are fine. People are worried about antibiotics. They're worried about antidepressants, all those things. The only thing I wouldn't mix heavily would be like a benzodiazepine, like an Ativan or a clonazepam, an anti-anxiety medication like that, or a sleeping pill. You can still drink with a sleeping pill. You just don't have 5 drinks. You have 1.5, 2. And same with the antidepressants. A lot of people are on these SSRIs, like a Cipralex or a Prozac type drug. You can drink with those. It's not going to alter how you metabolize the drug, but alcohol in itself is an upper and a downer. So it in and of itself does not help your mood or your anxiety level. People feel great when they're on it, and they feel way worse the next day. So why bother being on an antidepressant or anti-anxiety medication? But in terms of safety, it's really the benzodiazepines, the sleeping pills, the opioids, the painkillers, the morphine, the Tylenol 3s, things like that you need to worry about with alcohol. And there's only one antibiotic, and that would be metronidazole that you have to worry about with alcohol. Diet. Again, we talk about these things because they're true. So fish is better for you than meat. Eat more beans, but do so slowly, or else you're going to feel really bloated. You need to work up your fiber slowly if you're going to do it. Limit your red meat. Fill half your plate with veggies. That's just a great rule. It doesn't matter if it's lunch or dinner. Just half your plate is veggies. Use smaller plates and start reading labels when it comes to salt. And just use whole foods, like just real foods. You can keep it relatively simple. Find the time for exercise and make it a priority. You really have to. And that's hard for people who have been, getting to work at 7 every day and leaving at 7. They tend not to make it a priority. But in general, as when I talk to corporations and businesses, I try and say if all of you do it, then it becomes more normalized. If I have the CEOs of companies going out at lunch for a run, that's what everybody will start to do. So you have to just make it a priority. And it needs to be slightly vigorous. You need to be kind of uncomfortable, and it has to challenge you. So I have people say, I walk to work every day. But they've been walking the same route, 20-minute walk to work every day for 20 years. That's doing nothing, honestly. You need to challenge your heart. You need to be uncomfortable. You need to go do some stairs. You need to go up a hill. You need to increase your pace. And you can do it interval-wise. So we used to think, oh my God, I've got to be on the treadmill for over an hour in order to do anything. You could cut that hour down to half an hour if you're doing interval training, and then you're done for the day.
Yeah, I heard that instead of running for an hour, to go on and just do a sprint, then jog, or even sprint off.
Yeah.
Sprint on for 15 minutes would just do the same benefits to your.
Yep, exactly. I don't know the numbers on my head. If I had a kinesiologist here, I could ask them, but it's true. So studies now are showing that you can do way more in less time if you do it properly. The thing is, you don't want to be kind of one of those weekend warriors that doesn't really exercise and you go and you sprint up a hill and then you stop because you're just going to kill your Achilles and now you're out for 6 months. So you need to kind of cross-train before you get into that interval training, but it is at any age the best way to condition the heart and the brain and yeah. Okay, we've talked a little bit about these. Start exercising early, get your habits in, make it a priority, and it's never too late to take action. And get screened early. So again, I'm kind of 11 years out of the public system, so I don't know exactly what docs are doing there these days, but we make it a big priority that every year you come into Copeman and we do our checkbox and we look at your age and we look at your family history, we look at your personal history and your risks and say, yes, you need this now. No, we can wait till next year for that. There's a new study coming down saying that we should be doing this on you because, and I'm not sure if regular docs are on that or have the time to do that. So just make sure that you're going in, asking questions and getting screened. Yeah, exactly. That was my parents. No, I'm kidding. Okay, so this is interesting. This is, we can't prevent job strain. A lot of times we just can't. But if you can keep your lifestyle in check while you've got that job strain, you're going to be better off. So it's something you actually have control over. Sometimes we don't have control over job strain, but we do have control over lifestyle. So keep that in mind. And then I've got one more story just sort of about resilience here and how important that is. So this is a 34-year-old woman, very healthy, active, breastfeeding, little boy at home. Had a cough for 2 months, didn't go away, tried puffers, tried antibiotics, all those sorts of things. Ended up having 4 broken ribs because the cough was so bad, which doesn't happen very often. Some of you in this room have probably broken your ribs. It's not a nice thing. A few night sweats, but was, breastfeeding, and that kind of happens when your hormones are shifting a little bit. Itchy skin at night, especially for a couple of weeks. Ended up having 10 by 30 centimeter lymph mass of the left part of her chest. Received a phone call from a diagnosis, and within a week had the diagnosis of a Hodgkin's lymphoma. So the reason I put this up here is that was me the day before I was diagnosed with Hodgkin's with my little 8-month-old there. And I did well, obviously. Look at me. But part of the reason I did well is I had built up resilience. I was relatively healthy. I didn't drink too much. I ate well. I slept well, looked after my health. And what's interesting, And then I went on to be a spokesperson for Light the Night for Hodgkin's lymphoma and did all that. And I've got 3 pictures here, and it sort of makes you reflect on your life, and you don't ever know what's coming around the corner. But each one of these pictures, what is in common in those pictures is I had cancer in every one of those pictures, and that's over about a 3-year span, 2 to 3 year span, and I didn't know it. Okay? So you never know what's coming, but if you build that resilience in your health by doing all of these things that we talked about, then you can go through treatment and have one of these a couple years later. So I now have 2 healthy sons and everything is fine, but we can't, like, nobody would have been able to screen for that for me. It's not something you do in a 30-year-old. You don't do, blood tests looking for lymphoma all the time. So you're going to get these cancers, unfortunately, that do pop up, and they suck. It's like the stomach cancer in a 30-year-old. You're not looking for that, but it happens. And if you know your body and you know your symptoms and you know where you are from a risk point of view, then you know when to go in and get checked. And hopefully you have treated yourself well in order to get through that treatment program. But if you have someone who's overweight and they're smoking and not eating properly, and you try and put them on strong medications, they're not going to do as well in the outcome. Okay. So, any questions about anything there? Yes.
Well, I've just had my 10th annual at Copeman.
Oh, good for you.
How many cancers are you checking for when you're taking the blood samples and asking the questions and that sort of thing? Like, how much of the risk are you covering off that I don't have to worry about?
Yeah, no, it's true. So, if I'm thinking of you as a 49-year-old guy, 62. So when we do your blood tests and we do your full physical, we are covering off blood cancers, liver cancers, bladder cancer, kidney cancer, skin cancer, prostate cancer, where are we at? Colon, I said kidney, prostate, colon, blood, potentially lung, depending on your history. Did I miss it? Thyroid, covering off that as well. Retinol, if we're asking you the right questions. Brain, if we're asking the right questions, looking for the right symptoms. Yeah.
So I got nothing to worry about.
No, because I can't screen you for pancreas. I can't screen you for the throat cancer that's sitting there that you might not have symptoms of. So there's still things that you could potentially get that we just have no way to screen for. But the hope is you catch it early enough so that you survive it and you do well, right? Mm-hmm.
Could one get an entire MRI body scan sort of as a baseline and have that?
You can, yeah, and some people do. We're not huge proponents of that. The reason being is that if you go in and get a MRI, you'll likely rule out the bad, but you're also going to pick up some things there that we don't know exactly what they are. They're 99% likely benign, but now you need to go for a CT scan every 6 months to make sure it's benign, and now you've got the radiation from the CT scan to check something that you did as a preventative process anyways. Or now you've got a liver cyst that is likely benign, but now we've got to do ultrasounds every 6 months for a couple of years just to make sure it stays that way, and the stress of going in for the ultrasound for that, what we call incidentaloma. But then there's also the thing that, and I've had this with a patient. I had a patient who went for an abdominal ultrasound for something else. Everything was fine in the abdominal ultrasound. And 3 to 4 months later, she came in with tummy pain and jaundice. She had a massive pancreatic tumor that had grown in 3 months. And I had just done her ultrasound, 3 months earlier. So the same thing can happen with an MRI. It can give you false reassurance, but it can also lead you down a path that maybe causes too much anxiety. So whenever I let somebody go for a full body MRI, it really has to be the right person before I say, yeah, you can do it. You can go pay for one tomorrow, but if you're asking my advice, I usually really, really think about it before I say, yes, go do it.
What about a PET scan?
PET scan, a lot of radiation involved in that, and it's not going to, PET scans pick up certain things and not others. So usually we keep PET scans for if you have a known cancer and we're trying to figure out where it is in your body. and then you go for a PET scan. But PET scan as a screening test, I wouldn't do. If you're going to do a screening test, it would be an MRI.
How much is too much X-ray?
CT scans are the biggest ones, and they're actually becoming a little bit better in terms of how much radiation exposure you actually get. It just depends on the type of radiation exposure and how often. So if you're going for a mammogram every year or two, it's fine. Having a mammogram, the amount of X-ray radiation you get from a mammogram is like flying to Toronto, because we all get X-ray radiation when we're in the plane. So mammograms are fine. Bone densities, there's nothing. Ultrasounds, there's nothing. It's really the CT. So it's those people who are being screened for, say, a nodule in their lungs that we're not sure if it's cancerous or not, and often they're going for a CT chest every 6 months for like 3-4 years. At some point we say, too much radiation, the nodule hasn't changed, let's back off. If you're someone who has cancer and you're looking for recurrence, at that point, depending on how far the cancer had gone, you're not really too worried about that radiation exposure. You're more concerned about the tumor and actually finding it.
Dental?
Sorry?
Dental?
I wouldn't worry about X-rays of dental. It's the same as a mammogram. It's not much at all.
What about airports? Like, when I travel a fair bit, and they're getting lazy now. And they're making us all go into that machine that whirls around.
Yeah.
That was a lot. And I'm kind of, if I said yes every time, I'm going through that sucker 30 times a year.
Yeah. I'd say no when you can, if
Right.
you're a frequent traveler.
And I do.
Yeah.
But it's a pain. Then you go through the pat down, and they're getting very thorough now, and it slows everything
Yeah,
down.
I know.
Enjoy the moment.
Yeah. That's right. A little personal touch never killed anybody, right?
Well, it depends who's doing the personal.
Yeah. That's
But
true.
do you like, where would radiation on that kind of machine fall, or do you know?
Last time I saw it on kind of a graph, it was one of the least. It was sort of like more like a dental X-ray, not a big deal at all.
It's not a big deal.
Yeah.
Okay.
Yeah.
Are you concerned that mammograms are now once every 2 years versus once every year?
Yeah, I've kind of come around for that one. When it first came out, I was a bit up in arms because it really seemed that it was about money as opposed to actually truly screening for what they need to screen for. But when you look at the research, every 2 years in a woman who does not have super dense breasts is okay, especially after you've had a few normal mammograms. I'm never shy, though, to say, you've got dense breasts, I'm writing a letter, you're going in yearly. Or if you come to me with a mass, or not a mass, but like a lump, you're like, I don't know what's going on. I usually just say, let's just do the ultrasound just to be sure. Ultrasound, there's no radiation at all. So we still, in the big scheme of things around the world, screen more than most from a mammogram point of view. So we're still doing quite well there.
What's your best? Go ahead. What's your best way to test for heart disease?
A few things. So heart disease encompasses a number of things. Blood pressure.
Cardiovascular and the heart itself.
Yeah. So we're looking at your blood pressure. We're looking at your LDL cholesterol level. We're looking at your waist circumference. We're looking at your sugars. And then we get you on a treadmill to see what your heart does when you're actually stressing it, to make sure there's no ischemia or lack of oxygen to your heart. If there's any changes on that treadmill, we go to CT heart or CT angio, sometimes what's called a MIBI scan, sometimes an echocardiogram. So it's a bit of a stepwise approach to actually getting to the bottom of potential heart disease. If you've got positives on any of those, then we get you into the cardiologist for bypass, stenting, whatever is the problem. Yeah, and we've caught a number of people actually at Copeman through treadmills. Asymptomatic heart disease, get them on the treadmill, you see a problem, you get in the cardiologist, they end up with 3 stents.
And how often should you be tested after, say, bypass surgery?
For all of those things or just on a treadmill?
Well, you do your stress test, but you have bypass surgery. How often should you be tested again, in your opinion?
I'd say yearly treadmill.
Yeah.
For sure, and then make sure all of your parameters are at target. So LDL below 2, blood pressure probably down below 120 on 80. Yeah. Mm-hmm.
What's the best exercise for men to lose their belly fat?
It's not a whole bunch of sit-ups, unfortunately. A lot of people go to sit-ups. It's actually cardio. It's diet and increasing your cardio. Yeah, just to get the fat off. Yeah.
If your blood pressure is like 130, 35 or something like that,
Is it automatic medication, or will exercise and change of diet?
Yeah, it depends on where you're at. So if you're currently a couch potato, we're going to suggest lifestyle intervention, intensive lifestyle intervention with your team before we throw you on a medication. But if after 3 to 6 months you're kind of not able to make those changes and it's not helping, then we look at a medication. I also have some people who come in, they're just so far gone, from a lifestyle point of view, that it's going to take a couple of years before lifestyle intervention is really going to get them to target. So we throw them on the medication saying, you keep working at it and we'll get you off this medication. Mm-hmm. Anybody else? Any questions about anything in general? No? Okay, well everybody, oh yes.
I have one. I have a concern about the generic thyroid tests that are done through lab tests. And it would seem to me that there's relatively little information that's given, and that the testing does not go deeply enough to actually assess metabolic kinds of issues and potential problematics around thyroid.
Mm-hmm.
So what kind of testing of thyroid do you do that guarantees a more assiduous, definitive scale?
So we do your regular TSH as a screening, and then usually get a T3 or T4 on that. So you get your circulating thyroid as well as your pre-thyroid hormone levels. And then together with an exam plus or minus a thyroid ultrasound, we have a fairly good idea of what's going on. If you had a family history or a personal history of certain symptoms that might be due to thyroid, then we can start looking at thyroid antibodies as well. But we're not into doing salivary thyroid, for example, like some people might. But typically keep it to serum and exam, potentially ultrasound, depending on your presentation. Mm-hmm.
Do I understand it correctly that by doing the blood tests you can find the cancer markers?
Some cancer markers. So the problem with cancer markers is they're not all ideal. If you have cancer and we know that you have a colon cancer or an ovarian cancer, for example, we can start looking at I'm blanking, 15-3s. There's a few different tumor markers that we then follow to see if it's recurring or not recurring. But to do blanket tumor marker screening on everyone isn't always ideal because they're often high when there's not a cancer. So for example, CA-125 for ovarian cancer can also be high if you have endometriosis or if you're at a certain time in your cycle. So if I do a CA-125 on a 35-year-old and it's slightly high, she's freaking out for the next 15 years thinking she's going to get ovarian cancer, when really it's just because she's got a bit of endometrial tissue where it shouldn't be, in her uterus. So we tend to use those tumor markers for people who have already been diagnosed with cancer, and we're just making sure it hasn't come back as opposed to blanket screening. There was one more question that was just, sorry.
You probably have a lot of people that come in, they've Googled something and now they know what they have. Are there any websites that you do refer people to? Or
there definitely are, and all of our teams have different websites that they use more often than not. Our typical go-to from a physician point of view is one called UpToDate that only we have access to. But what I'll do is I'll bring up UpToDate on my screen with the patient and then email them the information that is pertinent to their question. So yeah, Dr. Google's not always great because there's always something there that's going to freak you out. So I always say, start with me and then we can look at it together. If you've already gone and done Dr. Google, then bring me the concerns and often we can talk you off the ledge.
Yeah. A friend of mine who is peripherally in the medical field said when you do go online, only look at .org, not .com.
Mm-hmm.
But at least that filters out a lot of the crazy stuff.
Likely, but you'll still get some crazy stuff. Yeah.
But it's anyway. I'm just passing that along.
Yeah, that might help. Yeah.
Just wondering what role genetics plays in health issues versus lifestyle. If your father had lung cancer, are you going to get lung cancer?
So hard to say. There's some cancers that are more genetically related than others, for sure. Lung cancer could be one of them. there's no great genetic test out there right now to say that you have a gene for lung cancer or you don't. There's just sort of those genetic tests that can say you have a slightly increased risk for lung cancer, but we know that already because your dad had lung cancer. So genes play a role for sure, but they're not the only thing, and there's a lot of things that we still don't know. We know the lifestyle, like we just talked about, has a big role to play, but there's still certain things out there, like I don't know what a cell phone is really doing to us. So probably in 50 years, we're going to look back and go, oh my God, we were stupid. Or, there's certain things that we don't know.
What about, the 23andMe and stuff like that? Any
Yeah.
thoughts on that?
Yeah, we get those reports often. And the problem with the 23andMe genetic test is, again, they kind of say, you have an increased risk of Alzheimer's disease. Well, what am I going to do with that? I'm sure maybe I'll eat more veggies, maybe I'll do some more Sudoku, but am I going to get it or not? Or, you have an increased risk of breast cancer. Well, they base that off the fact that your mother had breast cancer, as opposed to many other things. So it doesn't really help you that much. Where genetic testing can help you right now is which is super cool, I like this, if you have a certain types of cancers right now, they can do genetic tests on you to see if the chemo they want to use is actually going to work on you. And that's really cool. They can also do genetic tests, which we do on some of our patients, to see if the type of medication I want to put you on for your atrial fibrillation or for your depression actually is going to be metabolized properly by your body. Because some people aren't able to take certain blood thinners, for example, that we put them on for atrial fibrillation or post-stent. Their body actually doesn't react very well to them, and they might not be thinning their blood as much as they should, for example. So there are those directed genetic tests for medications now, which are actually useful. Yeah, but blanket genetic testing, not quite there yet. Good. Okay, well, thank you. If anybody has any questions, we'll be here for a little bit. And thank you, Terminal City Club, for having us. And thank you for everybody coming out. Hope that was useful.